they view? When did they chart? The data shows who played what part. Was a note changed? Was an alert displayed? The audit trail knows, while memories can fade. So whether you're a lawyer, nurse, or sleuth, pull up a seat, we'll search for the truth. Every click leaves a clue in the fray. This is what the chart won't say.
Hi everyone, this is Syra Pasha. Welcome back to What the Chart Won't Say. This is episode 5, and today I'll be going over a real medical malpractice lawsuit that I worked on involving a patient who died and allegations of negligence against the patient's primary care physician, an ED physician or emergency room physician, a couple of hospitalists, and a hospital system. This case goes to the very heart of what people think about when they think about EMR audit trails, determining whether or not a physician or a nurse changed a patient's medical records after a bad outcome or the patient's death. I'll start by showing a brief medical chronology that goes over the sequence of events based only on the medical records. Then I'm going to explain what the patient's family said happened, and there was a big difference between what they said happened and what was documented in one of the notes. Then I'm going to go over what the plaintiff's allegations were when they filed the lawsuit, then what the defenses were, and what some of the physicians said at their depositions. And then what I'm going to do is talk about what happened when I got involved, because that's when I got involved, after depositions. And I'll go over what I found in the audit trail and how I found it, generally speaking, and what I included in my expert report. If you're a clinician watching my video, it's possible that you'll want much more medical detail than I provide, and that makes sense. Clinicians naturally want to focus on the medicine, but I'm not a clinician, and so my goal is to show you enough of the backstory so that you can follow along and understand what I did in my role as an EMR audit trail expert. Trust that both sides had very good medical experts review the records for standard of care and causation. Both sides had very good attorneys representing them. So I'm going to stay in my lane, and we're going to be going over what kind of evidence was contained in the EMR audit trail and what did it show. Because one of the focuses of my channel is to educate people on the importance of reviewing EMR audit trails, and that goes for plaintiff and defense. Just a reminder, this video is not going to teach you how to analyze EMR audit trails. It's meant to show you what you can learn or what you can glean from an EMR audit trail and how important this evidence is in a medical malpractice case. If you want to learn to do what I do, you can get my book. Nope, upside down. You can get my book. I go over how to do what I do in a fair amount of detail and for beginners, so that's you. You can get a copy. And I'm also teaching a class February 28th and March 1st in the Chicagoland area, so maybe I'll see you there. Okay, a couple of other important points before I start the MedCron video. First, none of the images that you're going to see in the video are of real people involved in the case. They're either stock images that I licensed or they're AI images. And the video is only for educational purposes, just to give you, for storytelling purposes, for some background. And 2, the audit trail that I'm going to be showing you is not the real audit trail that was produced in the case, but it's going to be similar enough for you to understand the main points and the findings and how I made those conclusions. And And lastly, this is a real case, and I did get my client's permission before writing the script and making this video. So, all right, that's it. Let's get started. Actually, one more thing. Please like, subscribe, and leave a comment if you like this video. Normally, I say this at the end of the video, but I've found out that people don't usually make it to the very end of my video. So while I still have your attention, if you like my content and you want me to continue making it, please throw me a like and leave a comment. It goes a long way. Okay, now let's get started.
The patient was a woman in her 50s who underwent surgery on her left elbow for an infection. Following the procedure, she remained hospitalized for approximately 17 days due to complications that included an infected surgical wound that developed cellulitis. Cellulitis is a bacterial infection of the skin and the soft tissue beneath it. It can occur when bacteria enter through a break in the skin, such as a surgical incision or open wound, and then spread through the surrounding tissues, causing redness, swelling, and inflammation. During this hospitalization, her care was managed by hospitalists. At discharge, the only diagnosis listed was cellulitis of the left arm, and she was sent home with a wound vac on her arm. A wound vac is a device that helps a wound heal by gently removing excess fluid and bacteria through suction, keeping the area clean and promoting new tissue growth. 2 days after the patient was discharged, she began to feel unwell and developed a fever. On the 3rd day, her daughter called the patient's primary care physician and made an appointment for that afternoon. This physician had taken care of this patient for several years. The daughter went with the patient to her appointment. At this appointment, the patient's vital signs included a pulse of 151 beats per minute, a blood pressure of 131/94, and an oxygen saturation of 94% on room air. All 3 measurements were outside normal ranges. The chief complaint entered for this visit was fever, although the patient did not have a fever at the time of the exam. The history and physical section of the note referenced the patient's recent hospitalization. In the review of systems, the patient denied chest pain, shortness of breath, cough, and wheezing. The note also stated the patient looked visibly unwell. At this visit, the daughter asked whether her mother could get a PICC line. A PICC line is a thin, flexible tube placed into a vein in the upper arm and advanced toward a large vein near the heart. It allows long-term access for medications, fluids, or blood draws without repeated needle sticks. What happened at the end of this appointment became the subject of significant dispute between the family and the physician. The office exam note says the patient was directed to go straight to the emergency room for PICC line placement, and the doctor testified to this too. However, the patient's daughter testified that the doctor agreed to order a PICC line and said the referral would be ready the next day and that the doctor did not tell the patient to go to the emergency room. We'll revisit this issue later in the story. The patient's condition continued to worsen. She was taken to the ER the following night, more than 24 hours after the office appointment. This was not the same hospital where she had recently been admitted, but it was part of the same hospital system and used the same electronic medical record, or EMR, which allowed clinicians at both locations to see her chart. Triage documentation listed her chief complaint as vomiting and a low-grade fever, along with recent elbow surgery, a 2-week hospitalization, and ongoing antibiotic therapy. The patient also reported cough, chest pain, and generalized weakness. According to the record, she denied shortness of breath. The emergency room physician examined her and ordered a chest X-ray, which showed a suspected mild infiltrate in the lateral right lung. No additional imaging was performed. At about 11 p.m. that night, the ER physician called one of the hospitalists who had taken care of her during the prior admission. At that time, the patient had abnormal vital signs, including tachycardia, which means an elevated heart rate, low blood pressure, and a low oxygen saturation reading. Together, they decided the patient should be admitted. In the ER physician's note, he listed 3 diagnoses: arm wound, dehydration, and tachycardia. He also ordered antibiotics and in the order details wrote the word bacteremia, although he did not list it as a formal diagnosis. Bacteremia is the presence of bacteria in the bloodstream, which can sometimes lead to serious infections if not identified and treated. Over the next 2 days, the patient was seen by the same hospitalist from her recent hospitalization. His documentation described her condition generally, but did not identify what he was evaluating or what diagnoses were on his list of possibilities. About a day and a half after the patient had been admitted, at around 3:30 p.m., her vitals and labs triggered a SIRS alert. A SIRS alert is a computerized warning that a patient meets criteria for a systemic inflammatory response, which can be an early sign of sepsis or a rapidly worsening medical condition. At about 5:30 p.m., the patient was transferred to the ICU. She was reported to be restless and unable to follow commands. She then became lethargic and somnolent. A doctor was paged, and when the doctor arrived, the patient had no pulse. A code blue was called. Despite resuscitation efforts, she passed away that evening. An autopsy later revealed that the cause of death was a pulmonary embolism. A pulmonary embolism is a blockage in one of the pulmonary arteries in the lungs, usually caused by a blood clot that travels from the legs or another part of the body. It can restrict blood flow to the lungs, lower oxygen levels, and, if untreated, can be fatal. A pulmonary embolism is more likely to occur in the presence of certain recognized risk factors. These can include recent surgery, prolonged hospitalization, infection, elevated inflammatory markers, obesity, and periods of reduced mobility. This patient had undergone elbow surgery, remained hospitalized for an extended period, and had limited mobility during that time. When a person is immobile, blood flow in the veins slows, which can contribute to clot formation. A subsequent change in activity level, such as becoming more mobile after discharge, can allow a clot formed during immobility to move through the bloodstream and lodge in the lungs, resulting in a pulmonary embolism. This patient had several of these risk factors.
After the patient passed away, her family retained an attorney, and that attorney requested the medical records from both the primary care physician and from the hospital. And one thing that stood out about the records from the primary care physician was that the office exam note for the patient's very last visit was not signed until like 5 months later, and not until after the records request had been sent out. So, for example, using fake dates, imagine that the patient's last office exam was in June. Then the attorney sent out a request for records on December 1st. The note was not signed until December 7th, for example. So that means not only was the note, if you take it at face value, never signed until this records request was received, but it does raise suspicions as to, was there a previous signature or was this truly a first-time signature? And were there any edits made to this note? Because it looks like it's in reaction to getting a request for the patient's medical records. And in my experience as an audit trail expert, I wouldn't say this is common, but I also wouldn't necessarily say it was uncommon to have notes that remain unsigned for a couple of weeks or a couple of months, not years, but I have seen that in a couple of cases, and I've seen it go both ways. I've seen it where there truly has not been any substantive change to the record, and it really just remained in draft status for a month or two and then signed late. And I've seen significant changes made to notes when they're signed late, and sometimes I see a previous signature that was removed altogether, and then so like a note was signed and it's like unsigned, and then the substance is changed and signed again. So that's where the audit trail comes in. That's where it's very important to review that metadata to objectively determine whether or not something was modified in the note. A late signature by itself means just that, a late signature. We don't know enough, and we need to look at the audit trail and revision history for the note. Okay, so for the next part of this video, I'm going to show you what plaintiff's allegations were, generally speaking, in her lawsuit, And then I'm going to take snippets from the defendant physician's depositions, and I'm going to paraphrase them, but I'm going to pull out, generally speaking, like what they said, what the defendant physician said at their depositions in defense of their own care. And I'm going to be using AI videos. They're not meant to represent the physicians. They're just meant for education and storytelling purposes. And the words are going to be paraphrased, but I'm going to try to keep it as close as possible to what was really said. After that, I'm going to go over what my role was in this case as an audit trail expert.
In this case, the plaintiff alleges that multiple providers missed a critical diagnosis. According to the complaint, the physicians should have considered pulmonary embolism based on the patient's presentation, ruled it out with appropriate imaging, and initiated treatment when necessary. The plaintiff argues that these steps were required by the standard of care, and that the failure to take them allowed a pulmonary embolism to progress undetected. The central claim is that this missed opportunity ultimately led to the patient's death. The following 3 videos are narrative summaries of what the primary care physician, emergency room physician, and one of the hospitalist defendants said at their depositions in defense of their care against these allegations, and what the primary care physician said about the last office exam note that was signed 5 months later. The AI avatars used are not meant to depict any actual person involved in this case.
When I saw this patient in my office, nothing about her presentation led me to suspect a pulmonary embolism. She was weak and clearly unwell, but she was not short of breath, her lungs sounded clear, and her heart exam was normal. Given her recent surgery and hospitalization, I was more concerned about infection and dehydration, and I felt she needed a higher level of care than I could provide in the clinic. Sending her to the emergency department was, in my judgment, the appropriate next step and consistent with the standard of care. I finalized my note months later, and while I may have corrected spelling, grammar, or sentence structure, I did not add new clinical information or make any substantive changes to the record.
When I evaluated this patient in the emergency department, I acted based on the information in front of me. Her symptoms, vital signs, and exam did not suggest a pulmonary embolism, and the chest X-ray showed a mild infiltrate, not a pattern that would indicate PE. Pulmonary embolisms can present in many different ways, and nothing about her presentation that night led me to suspect it. I focused on the issues that were actually supported by her clinical findings: tachycardia, dehydration, and signs of infection, and I treated those accordingly. I reviewed her diagnostics toward the end of the encounter, made the decision to admit her, and believed that everything I did was appropriate and consistent with the standard of care based on what I knew at the time.
When I evaluated this patient, nothing about her condition led me to suspect a pulmonary embolism. The chest X-ray showed an infiltrate, which I understood to indicate infection or pneumonia, not a clot in the lungs. Her elevated lactate level was consistent with dehydration or infection and improved with hydration, which reinforced that assessment. Based on her history, exam, and the studies performed before I saw her, I believed her clinical picture fit sepsis, not pulmonary embolism. I acted on the information available to me and believe my evaluation and treatment were appropriate and consistent with the standard of care. I did not alter or omit any documentation in her chart, and I was genuinely surprised when I later learned she died from a pulmonary embolism.
We've now gone over the patient's medical chronology, what plaintiff's allegations were, and what the physician said at their depositions in defense of their own care. And that's where I got involved after those depositions had been completed. And what my role in this case was, well, my client asked me to do 3 major things. Number 1, determine whether or not there were any substantive changes made to the patient's last office exam note, the one that was signed 5 months later. Were there any major changes beyond spelling, correcting typos, as the physician testified? 2, read the transcripts of all the defendant physicians and determine if anything that they said was inconsistent with the objective audit trail data. And then 3, construct a tight timeline of care based on the data in the audit trail and the medical records. And that was especially important in this case because nearly every physician and nurse who gave a deposition said they did not remember this patient. So they could only rely on the medical records. And that's fine. I mean, it makes sense that, if you see a patient for a couple of days and it was a couple of years ago, you might not remember the details. But why only rely on medical records when we have objective data that was recorded by the system contemporaneously, and it can be used to reconstruct what people saw in the chart, what they clicked on, how long they viewed it for. Maybe some people are in there that were not in the medical records. So it's very valuable to reconstruct a timeline based on that data, and I think it's very meaningful to jurors. So I'm going to go ahead and show you a clip of a summary of the main findings or major conclusions that I reached in this case. I'm not going to be showing you the real audit trail, and I'm not going to be showing you the real medical records, obviously, but I made mock examples that are similar and are good teaching examples. So, all right, I'll go ahead and show that now, and then I'll see you after that.
Recall that the note included in the printed medical records said the patient was told to go straight to the ER with an order for a PICC line, and that the patient's daughter testified this did not happen. This is what the audit trail from the primary care clinic showed. Dates have been changed, but the times are either the same or similar. The mock audit trail excerpts shown have been simplified and do not reflect the complexity of the real audit trail that was produced. The note from the patient's final office was saved as a draft on the day of the patient's last visit, and it remained unsigned for months. That draft did not contain any mention about sending the patient to the emergency room. This draft note also did not contain the HPI and review of systems portions of the final note. There was a reference to an order for a PICC line, but the actual order was not entered until the following day, which is consistent with the daughter's testimony. A little over 5 months later, the family's attorney sent a request for the patient's medical records. A clinic employee logged the request in the EMR, then sent an internal message to the physician asking for the final note to be signed so the medical records request could be completed. The physician saw the message about 15 minutes later. Soon thereafter, several modifications were made to the existing draft note. At 4:48 p.m., the words "to ER now with order to start PICC line" were added to the existing plan portion of the exam note. At 4:53 p.m., the words "await ER notification" were added to the existing plan portion of the exam note. At 4:56 p.m., the HPI portion of the note was created for the first time and added to the note. At 5 p.m., the review of systems portion of the note was created for the first time, and then the doctor signed the note. The primary care physician testified she made no substantive changes to the note for the patient's last office exam.
I finalized my note months later, and while I may have corrected spelling, grammar, or sentence structure, I did not add new clinical information or make any substantive changes to the record.
But the audit trail established there were 4 significant substantive changes to that one note. Now let's turn to the audit trail for the hospital. Because every physician and nurse testified they had no memory of the patient, the audit trail played a central role in reconstructing the sequence of care. All of the physicians who examined the patient at the hospital testified that they were working up the patient for sepsis, but the medical records did not contain any mention of sepsis. The audit trail was reviewed, and later an EMR inspection was performed to confirm no documents were modified or deleted that would have supported the theory of this unified defense. No contemporaneously created evidence supported the defense that any of the physicians were working up the patient for sepsis until a sepsis alert fired on day 3, about 2 hours before the patient coded. The order for antibiotics did include the word bacteremia in the comments. However, bacteremia and sepsis are not the same. A patient can have bacteremia without developing sepsis, but sepsis implies a much more severe and widespread clinical condition. The hospital's audit trail also contained evidence of an employee from the primary care clinic logging into the hospital's EMR system and reviewing records, including when the patient was in the ICU after she coded.
So, what did you think? Was it interesting? Was it surprising? Please leave a comment and let me know what your thoughts are about the case, about my work, whether you agree that audit trails should be reviewed in every medical malpractice case. Hopefully the answer is yes. Well, the answer is always yes on this channel, right? In case you're wondering what happened in this case, it settled before trial. I think it settled 2 months before trial, and it settled before any defense expert disclosures were filed. And that's why I made sure to include statements from the defendant physicians' depositions, because I wanted to be open about what they said to defend their own care. Because normally I would use expert disclosures, what the defense said in their disclosures, but this case never went that far. So that's why I used deposition statements. I think this is a good video to emphasize why defense attorneys need to be reviewing audit trails as they prepare their clients for their depositions, so that they don't make statements that are inconsistent with the objective data. Well, that's it for this video. If you enjoyed my content, if you want me to continue making additional videos, please show your support by liking my video, subscribing, and leaving a comment. That's it for this video. This is what the chart won't say, where we follow the data and let the facts speak for themselves. Bye.
For professionals in the medical legal field who want to learn how to analyze EMR audit trails, this book was written for you. What the Chart Won't Say is a practical, step-by-step guide that explains how to read, interpret, and understand EMR audit trails in medical malpractice cases. It was created for attorneys, legal nurse consultants, risk managers, and medical professionals who need a clear and approachable introduction to this complex topic. In-person classes will also be offered in early 2026 in the Chicagoland area for those who want to expand their knowledge and apply these skills in practice. Instructions for purchasing the book and signing up for classes will be announced on November 1st.